I'm Josh Mailman. I'm the president of NorCal CarciNET community. This is our bi-monthly UCSF NorCal CarciNET community meeting with UCSF. I'm here with Lacey, who is with UCSF, and will be helping us in the second hour facilitating our group. And it is a great pleasure. One other housekeeping thing. Many of you who got the email earlier know that if you want to add questions, you can use the webinar as well. There's a Q&A area, or you can go to slido.com/NorCal to add questions in as well. And for those of you who are watching this on Facebook, you can add the questions there as well so that we can ask them later on. But with that, it is my pleasure to introduce someone who many of us know because we are patients at UCSF. But Dr. Nick Fidelman is here. He is Director of Interventional Radiology at UCSF, and he specializes in colorectal cancer as well as neuroendocrine tumors. And so without further ado, I'm going to stop my screen share and have Dr. Fidelman do his screen share. Dr. Fidelman, welcome, and please feel free to share your screen, and Lacey and I will go away and let you have the presentation.
All right. Josh, thank you so much for the introduction, Lacey, for helping organize this event, and for all of you who are attending. As Josh has said, my specialty is interventional radiology, and particularly with what we can offer in the realm of IR, among many other things, is liver-directed treatment for neuroendocrine tumors. And as you all very well know, the landscape of treatment has changed a lot in the last 2 years with the FDA approval of Lutathera for peptide receptor radionuclide therapy, PRRT. And that really has called into question everything that we kind of took for granted as far as treatment and sequencing treatments. And so the purpose of today was to really kind of overview what we can still offer for local liver tumor treatment and how that might fit in our current era of PRRT. So a couple messages for today's talk. One is that liver-directed therapy in general continues to play a number of very important roles in the era of PRRT, and that getting a consultation from an interventional radiologist for treatment of liver tumors specifically may make sense before switching treatments, because there may be a reasonable window to do something local rather than to go to another systemic therapy or PRRT. And I'd like to start by getting a quote of one of my patients from many years ago, who reported that lower abdominal pain that he has been experiencing for the past 15 years is now completely gone. And this is after one Y90 treatment. And he used to have 7 to 8 loose bowel movements a day, and now he has only one solid bowel movement per day. So this pretty much sums up what we're oftentimes able to accomplish by performing liver-directed therapy. By reducing the bulk of the liver tumors, we can really help with the symptoms. We can really help improve the way people feel. Now, ideally, of course, in the ideal world, everybody would get an operation and these tumors could be cut out. But if they cannot be cut out, what else can we offer? If there's multiple tumors in both lobes with little or no disease outside of the liver, with tumors growing or continuing to have symptoms despite other treatments such as octreotide, everolimus, PRRT even, we can help by reducing the bulk of the liver tumors. The risks of having untreated liver tumors are really a big number. First of all, of course, carcinoid syndrome and other hormonal syndromes can be a problem because these tumors produce hormones. Specifically for mid-gut carcinoids, they can exacerbate carcinoid heart disease because these hormones, once they leave the liver, go to the right side of the heart and can cause valve damage of the heart valves. Other hormones can be produced, such as insulin and so on, for certain types of neuroendocrine tumors. The tumors also have occupy space physically and replace healthy liver. Now, they grow slowly, and so there's plenty of time for healthy liver to just regenerate. But when they start reaching certain sizes, they can start obstructing things. They can start blocking the portal vein, which is a big vein that brings in nutrients into the liver from the gut. They can start blocking the bile duct and ultimately can start contributing to liver dysfunction. So they can cause various problems over time. And so the goals of liver-directed treatment really are to turn back the clock. It's not a curative, none of these treatments are really curative. People wait long enough, something will regrow back. Maybe not right where it was treated, but maybe something else will regrow, but they'll regrow back. And so it's turning the clock back. It is to reduce the hormone symptoms, to reduce the risk of carcinoid heart disease, and to delay any kind of bad liver side effects. What is liver-directed treatment? What is it that we're talking about? Well, it obviously targets only the liver tumors, nothing outside of the liver. And there's different ways to treat, and we'll keep kind of repeating this to go over this. But one of the approaches is called ablation, which is application of extreme heat or extreme cold. Usually it is reserved for when there's few tumors, no more than 3 or 4, and that are not of very big size, under 3 centimeters. And they also, another caveat is they have to be in a favorable place anatomically, away from other vital structures like the intestine, the diaphragm, gallbladder, major vessels, so that those structures don't get damaged in the process of application of that extreme heat or cold. The other approach that we use a lot more often, because it's a lot more practical and in many ways easier to tolerate than having to have these ablation under general anesthetic, is injection of therapeutic agents into blood vessels that supply the tumors. And there's different things that can be injected. You can inject tiny particles to block the vessels, and that's bland embolization. Chemotherapy in oil and particles injection is called chemoembolization. And then tiny particles containing radioactive material, that would be radioembolization. And we'll keep kind of repeating these concepts a little bit. So again, that slide basically shows the same thing, but just to show that if there is one or couple spots that are relatively small that we're dealing with, microwave ablation or cryoablation are good applications. Mostly in the liver, we use microwave nowadays. Whereas if there's multiple spots, like you see, this is a DOTA PET CT, which is showing an overlay of the DOTA avid tumors in the liver that's here. And you see there's multiple spots. So there's multiple spots. Ablation is really very difficult and essentially not a possible way of burning everything inside. So treatment through the vessels or embolotherapy is really would be the treatment of choice. It's worth mentioning briefly the vascular anatomy of the liver. And the reason that the embolization works in the liver is because liver has 2 blood supplies. There is the portal vein, which is this structure. I hope you can see my pointer. Usually you're able to see the pointer. There is the portal vein, which is in purple and pink, which brings the blood and nutrients from the intestine. And then in red, this thin little structure is the hepatic artery, which also brings oxygen and nutrients, but only 25% of that comes from the artery, and 75% comes from the vein. Now, as it turns out, malignant liver tumors derive 97 to 100% of their blood supply from the artery, and almost none or none at all from the vein. So as a result, if we treat through the artery, we disproportionately interrupt vascular supply to the tumors and keep the healthy liver relatively intact, free of any kind of toxin. And that allows the tumors to die as a result of the treatment and the liver to recover. So that is basically, this slide basically says what I just said, repeating it, also mentioning that when we look at perfusion, or the amount of blood flow that the healthy liver is getting versus what the tumors are getting 5 to 17 times more blood flow through the artery than the healthy liver. So by that inference, when we inject therapeutic material into the artery branch, the tumor is going to get 5 to 17 times more than the healthy liver that's surrounding it. And so that's why embolizing the artery works and is safe generally. So liver-directed treatment, whatever it is, provides a very effective means of rapid liver tumor debulking. And it is really rapid. It takes literally within days for embolization and ablation to, well, ablation, you'd argue, is instantaneous, really. It just takes minutes. Takes a couple of days for embolization, and for radioembolization, or Y90, takes a couple of weeks. The tumors shrink and are very likely to shrink, and I'll show you data to prove that. But let's just take a little step back and just talk about embolization in general. How does embolization work? Well, it's blockage of artery branches using little particles. Here is a syringe with a pellet of particles. Here they are. There's hundreds of thousands of them in there. This is a little catheter in a vessel, this white thing. And then these particles are being injected and are carried with blood flow into the tumor vessels, and some amount goes into the surrounding healthy liver, and then they just get deposited inside the tumor microvasculature. And if it's chemo, then the chemo goes inside the tumor. If it's radiation, then the radiation gets emitted into the tumor that way. And it's done in the interventional radiology suite that kind of looks like this, minus the green lighting. This big installation here with this C is an X-ray camera that rotates every which way and could even produce CT scans if needed for confirmation. And we usually go through the groin to get access and to put our little tubes inside the body through the groin. And then we have these TV monitors where we see what's happening kind of in real time. And so we already talked about, but it's worth repeating again. So what are the three things that could be injected into the vessels? And what we use are tiny particles alone to black the vessels and cause oxygen and nutrient starvation. That's bland embolization. We use chemo and oil and particles, otherwise known as chemoembolization. Now, tiny particles containing radioactive material, yttrium-90, which is radioembolization, otherwise known as SIRT, or selective internal radiation therapy, or Y90 simply. Which of one of these is the best? The short answer is we don't know. We're working on trying to figure this out, but we're years, if not longer, from figuring out the answer. Well, we know that what we do know is that we know expected effectiveness of each individual treatment. We know the expected side effects, and that we make individual recommendations based on where the tumors are located, their size, health of the liver, and the person's overall health, in order to best recommend one of the three. So let's just talk a little bit about the bland embolization. That's the one where we don't use any chemo or radiation, just tiny little particles injected inside the tumor vessels. They're really quite tiny. Typical range is 40 to 300 microns. Just for reference, a red blood cell is 8 to 10 microns. So these particles are not a whole lot bigger than a red blood cell, just about 4 to 5 times bigger for the smallest ones we use. We usually start with the tiniest ones, because what we want these particles to do is go as deep inside of the tumor vessels as possible, so that the tumor doesn't have a chance to regrow new blood vessels. Now, over time it would. We just don't want it to happen for a very, very, very long period of time. And so we found that using the tiniest of the particles seems to correlate with how long the tumor stays shrunk. They block the arteries, they cause oxygen and nutrient starvation. That's how the treatment works. Depending on on who you read, and in our experience, symptomatic improvement and imaging improvement are very, very common. 80 to 90% of the time, maybe even 90% plus, we see a significant improvement in the size of the tumors and in the amount of hormone that's produced. And oftentimes, if it's a hormonally active tumor and causing a carcinoid syndrome, for instance, we would expect that people would feel significantly better, less flushing, less diarrhea. If it's an insulin-producing tumor, we would expect blood sugars to normalize. And we use this treatment to normalize blood sugar and to help with the carcinoid syndrome. Same thing goes with people who have very high 24-hour urine 5-HIAA urine hormone that correlates with potentially with development of heart disease. And we use this treatment to decrease the amount of hormone in the bloodstream, and it's a very effective way of doing that as well. How long does it work? It works for up to several years. And the duration of action of this treatment really depends on how fast the tumors are growing in the first place. The slower they grow, the longer it takes for the tumors to regrow. The faster they grow, the faster they'll come back. Usually they'll come back at whatever pace they have been growing. Usually the pace of growth does not change as a result of the treatment. All right, chemoembolization is very, very similar. Now, instead of giving little particles, we use this, what looks like an emulsion, oil and vinegar. You can imagine oil and vinegar if you shake it together very, very, very vigorously until it becomes this homogeneous, thick, gooey sort of liquid. That's what it looks like when a combination of a drug is mixed in oil-based contrast. So that stuff, that gooey stuff is injected. It causes the chemo to really kind of percolate inside the tumor capillaries. And then particles are given behind it to prevent the chemo from going out of the liver to the rest of the body. So as a result, about 95% of the medication stays in the treated liver sector, and only 5% goes to the rest of the body. So we're using very low doses of chemo for this local treatment, and very small amount is expected to reach the body, the rest of the body. There's also an option of chemotherapy impregnated particles, but we'll talk about that in just a second right now. So this chemo and oily contrast mixture, this is what it looks like. Lapiodol, yellow stuff, that's the oily contrast, and the chemo, one of the drugs that we commonly use is doxorubicin. That stuff is red, and so it causes that whole mixture to become red when it's injected. Mitomycin C is colorless. That's the second drug that we give. The other option with TACE is using what's called drug-eluting beads. And these are the beads when they come in from the manufacturer. They're blue, and when they're mixed with doxorubicin, doxorubicin gets impregnated into the beads, and the beads turn red as a result. So this is after they're impregnated with the drug. And then the drug leaches out of the beads for a period of about 12 days. And these particles also cause some blockage of the blood vessels. So it in essence creates the same effect. But what we found out is that quite a few people who were treated with this regimen with the drug-eluting beads developed bile duct problems, either strictures or narrowing of the bile ducts or fluid collections of their bile inside the liver, which is a bad and sometimes difficult to treat problem. And so because of the high incidence of this kind of a complication with drug-eluting beads, we no longer recommend use of drug-eluting bead chemoembolization specifically for people with neuroendocrine tumors. But conventional chemoembolization, that's that oily stuff, oil and drug together, that's what we would use, but not the drug-eluting beads. And why go too fast? So chemoembolization effectiveness, now from the same study, 80 to over the 90% chance of a meaningful, significant improvement, both of the hormonal symptoms as well as of the tumor appearance on the scans. And again, the duration of treatment, again, on the order of months to years, depending on how fast the tumors grow. Just like with bland embolization, very similar outcomes. What are the side effects? Side effects most commonly would be post-embolization syndrome of conventional chemoembolization and bland embolization. And the post-embolization syndrome consists of abdominal pain, feeling nauseous, fever, decreased appetite, and fatigue. And also very commonly, we see a problem with the blood tests on the next day that usually persist for about a week or so and then get better. Those side effects are very common, but none of them are dangerous. They're bothersome. They're worse in the first week or so and then get better. There's few rare but serious side effects. Number one, liver dysfunction, especially if liver dysfunction is not normal going in. Liver could take some damage as a result of these treatments, although that is very uncommon. I would say less than 2% risk of lasting liver damage from these treatments. Infections can happen. The risk of an infection is about 1 to 2%, and infections can be serious and may require additional procedures such as drainage of an abscess or a blocked bile duct to treat. Liver infections can be difficult or may require taking antibiotics for a very long period of time. On occasion, kidney dysfunction, that's very rare and really mainly a problem only for people who have abnormal kidney function to start with. And this has to do with the use of the X-ray dye that we have to use in order to take pictures of the blood vessels in the process of doing the embolization treatment, rather than the treatment itself. Then another thing that can happen with the treatment is that the carcinoid can hypersecrete, these tumors can hypersecrete hormones, and carcinoid crisis can occur, which shows itself by flushing, may cause face or throat swelling and difficulty breathing, may cause abdominal cramping and back pain, and may cause various blood pressure and heart rate problems also. The overall risk of that seems to be around 20%. Now, vast majority of the time, this carcinoid crisis is not at all life-threatening. It's a transient thing, temporary thing that just we know during the procedure it happens. It doesn't have to have all of these different things. Sometimes just somebody turns very deeply red during the procedure, and we give them some extra octreotide, and it just passes on its own. Problems with blood pressure, for instance, or anything really life-threatening, exceedingly rare. 22% is pretty much, any kind of a carcinoid reaction that happens during the procedures. There's various medications that we give. Octreotide is one of them. We like to make sure that a long-acting octreotide or lanreotide shot is on board soon before the procedure is done, so that the amount of that long-acting hormone is not waning in the body. But we also give additional octreotide, both through an IV and by a subcutaneous injection. And we give some additional medications for people who have very severe carcinoid syndrome. To start going into the procedure, we will have an anesthesiologist monitoring. Otherwise, a sedation is usually given by a nurse if we don't feel that the risk of carcinoid crisis is very high. So how does the bland and chemoembolization compare to each other? Well, this is the same study, just put together that table back for you. You see the numbers are really kind of very, very similar. I wouldn't make much out of this difference, 88, 24 months. This is, really the duration of the effect of both of these procedures is very, very similar, as you can see in this graph from another study. 100 patients from 3 different centers in the United States basically showed that survival was identical regardless of whether people were treated with chemoembolization or just bland particles, and the side effects were identical between these two. But nevertheless, which one is better? We want to know, and we do not know currently. Chemo may have an added benefit because you add a drug to particles, but may cause some additional chemo-related side effects that we weren't able to discern because the studies that we have so far involve small numbers of people and are all retrospective, meaning that somebody looked back at charts and charting may not have been perfect. There may have been a lot of missing information. There may have been, especially about side effects, a lot of this information about side effects in retrospective studies is missing because side effects are not always documented, or somebody goes to some other hospital, to another doctor, it doesn't make it into a chart. And we get very, very spotty knowledge from retrospective studies. So as a result, we need to do prospective studies. Prospective meaning that we do a treatment on a study and then follow forward and see how effective and safe a particular regimen is. And so with that in mind, we have a randomized study that's ongoing. It started about 3 years ago called the RETNET trial, which has been put forth by a University of Pennsylvania. And UCSF is one of the sites, and so is Stanford. We're sites, and we're looking for people to participate, and it's a randomized study. So that means that we let the computer decide between bland embolization and chemoembolization. There's no placebo. Everybody gets very effective treatment, as you saw from what I've shown you. We just take the decision out of our hands, and in many ways it's somewhat liberating because I don't personally know how to best advise for one versus the other. People have certain preferences. Some don't want to have chemotherapy, and some want to give kind of the biggest shot that we have. But it's not really based on good data at all. And so doing it as a part of the study, which is still a very, everybody gets effective treatment, is probably a good option. So this study is open. And so I just wanted to show you some pictures of how well this all actually works. And it works remarkably well. This is a person who has grade 1, so the most indolent form of a carcinoid, very slow growing, and we treated with just bland embolization. And this is their liver, and this was a tumor. And this is how much it shrank just 3 months out. I mean, you can see by volume, it's probably down to a quarter, and it no longer has those enhancing or viable parts of the tumor. It's now all black and completely dead on the inside. And we would expect this kind of an effect to last for a very long period of time. Here's another person who came in with more aggressive form of carcinoid with a Ki-67 index of 19%. The lower that number, the slower the tumor grows. And you see there are many tumors here. This is the liver. And all of these gray discs are tumors there. And then after the chemoembolization, you see these gray discs are largely gone. What you see are these white discs now. So those are dead tumors that have that oil-based contrast. These tumors retain contrast for months and years. And actually, the longer they retain contrast, the better the tumors tend to respond. If they're retaining contrast, means that the tumor is completely dead. It's just now becomes this container, this vessel containing the oil-based contrast, and whatever is left of the chemo is gone also. It's just what's left over is the oil-based contrast and the dead debris of the tumor. And we'd also expect this to last a while. This is the same person, the DOTA scan. So DOTA scan, where we're looking at a whole body here, and only the areas with somatostatin receptors are showing up. And so what you're seeing here is the pituitary gland. That's a normal place where there's somatostatin receptors, so it's always will show up on the DOTA scan. And you're seeing kind of like faint outline of the lungs and of the heart here. And this is the liver that has many tumors. You see it's almost completely black because there's tumors all over the place there. And then what you also see here is a tumor in the small intestine. That's where it all came from. And then the bladder is excreting excess radioactivity, so the bladder is black. So this is what happened a few months later after we completed 3 chemoembolizations for these liver tumors. You see, you can compare the amount of blackness in the liver to the amount of blackness in the liver here. We didn't get rid of 100% of it, but certainly seems to have got rid of a huge majority, probably 90+% of it is gone. Now you can actually even see the kidneys and the spleen, whereas before you could barely see them because the liver was so dark. And you see over time, some things got a little worse. Looks like there's a couple extra spots here, maybe little lymph nodes, although maybe they were there in the first place, but there's clearly a new spot there. That's a lymph node and looks like a new spot in the bone. So that we didn't address, right? Because we just treated the liver. And so the tumors can get worse over time. As we're watching the liver tumors shrivel up, something else might appear somewhere else. What about yttrium-90 radioembolization? So that treatment has also been around for a long time. It was introduced in the 1980s, and it involves administration of these tiny 20 to 60 micron particles that carry with them yttrium-90. And there are 2 agents on the market in the United States that carry Y90. One is resin agent called Sursphere. It's FDA approved for treatment of colon cancer tumors in the liver. And the other one is glass, and it's Therasphere. It's FDA approved for treatment of primary liver cancer called hepatocellular cancer. And for neuroendocrine tumors, we predominantly use resin because resin carries less radioactivity than glass and is a better agent for treatment of larger liver zones, as opposed to glass is being better designed for treatment of delivering very focal, very high radiation doses. Yttrium-90 is the active ingredient. What's important here is that its physical half-life is about 2.5 days. So you figure it works for about 5 half-lives. So it's active in the body for about a period of 2 weeks. And it has a very, very small zone of penetration. 2.5 millimeters is less than 1/10 of an inch. That's how much beta radiation will penetrate away from the tumor. And so the beta radiation really is concentrated very much in the zone where these particles are deposited. Radioembolization is also, similarly to bland embolization and TACE, is very, very effective with the chance of an improvement on the scans of up to and upwards of 90%. So again, also a very effective way of treatment with, again, the treatment lasts, how long the treatment lasts very much depends on how fast the tumors are growing. The slower they grow, the longer the treatment tends to last. Some examples of these big tumors shriveling up and becoming these little dead areas of dead tumor just 3 months after a single radioembolization treatment. Here's a person who was treated twice with radioembolization. This is the liver. The tumors are bright white here because they're enhancing with contrast. We treated the right side first, and you see just a month later, all those white things are gone. All you have here is the stuff that's left over in the left because it hasn't been treated yet. And then another MRI 3 months later for the right side, but only 1 month later for the left. And you can see it's as if somebody's turning off the lights on these tumors. And then after a response like this, which is a really, really good response, we would just watch with MRIs and just monitor. Potential side effects. The common ones are what's called constitutional. They're the common ones, mostly feeling tired, but also some nausea, decreased appetite, abdominal pain, taste changes can occur. They're common, especially feeling tired. Almost everybody feels tired. It usually lasts about 2 weeks, but can sometimes last longer, depending on how somebody feels before the treatment. It depends. The more severe and significant side effects have to do with, again, liver damage potentially with radiation. On occasion, intestine can get affected and ulcers can form. That's very rare, about 1 to 2% of the time, and exceedingly rare gallbladder and lung damage. So there's probably a role for all three of these treatments, and um, that's kind of what I want to talk about for the rest of the talk. But before I do that, just want to kind of give you a sense of a comparison between bland embolization and TACE and radioembolization in terms of the severity of the side effects. The abdominal pain and nausea tend to be much more common with bland embolization, but tend to last a week to 2 weeks. First 1 to 3 days are the worst, whereas fatigue and loss of appetite are the more common ones after the radioembolization and tend to last longer because radiation tends to stick around for a longer period of time. As far as radiation safety for Y90, with the beta particle deposition within the tissue, as a result of the interaction with tissue, low dose X-rays get emitted, very small dose of low dose X-rays. And so we recommend that people sleep separately for 3 nights after the radiation treatment so that they don't get a loved one radiated, but it's a very, very low amount. There is no radiation in sweat or saliva. With the resin, there's a minimal amount in the urine. So we ask people to flush the toilet twice and to limit the number of droplets that get formed with urination, just to prevent any radiation spread to the household members. All right, so what are some of the possible roles? And maybe I'll just go through fairly quickly all the other stuff because it's 12:39 already, and if you want me to stop at any point and we'll just switch to questions, we could do that because there's a number of different roles for liver-directed treatment, and the most obvious one is just debulking or decreasing the amount of tumor in the liver when there's liver only. Or liver dominant, or mainly in the liver tumors. So here's a DOTA scan where there's multiple spots in the liver, and there's the primary tumor. So this might be a good indication because you see that the tumors are pretty much only in the liver except for the primary tumor. Or this person, I already showed you the scan, lots of liver tumors, but they're only in the liver except for the primary tumor. Or this person where there's lots of liver tumors, but there's also some lymph node spots and some bone spots. So, but there's still more in the liver than outside of the liver. So it still makes sense to target the liver, especially if the stuff outside of the liver is relatively stable, maybe on octreotide. Another example of the same thing, there's more happening outside of the liver here. You see many, many spots. Most of these spots are probably in the bones, but there's still a lot in the liver, and the largest areas are in the liver. And so oftentimes we would treat the liver to get that under control while maintaining a person on sandostatin and to make sure that these spots don't get out of control. So to sum up that, it has to be predominant, the tumors have to be predominantly in the liver or only in the liver for this to make sense. And if there is tumors outside the liver, there shouldn't be too many, and they should be fairly stable and not causing symptoms, because if they are, then just targeting the liver is probably not the right thing to do. Catching the right window is also very important. This is the same person 2 years apart. This is DOTA scans again. So you see, at first they only had pretty much only in the liver a few bone spots, very small. And then 2 years later, there are a lot of bone spots, and clearly it's getting worse over time. So this would be the right time to treat the liver. Image on the left. Image on the right is not the right time to treat the liver because the bones are getting worse. So maybe something like PRRT would be a better choice of treatment there. What about maintenance? Yeah, so you can use maintenance liver-directed treatment with concurrent octreotide or lanreotide. So here's an example of that. This is a person that I met 10 years ago, the very big liver tumor, had a very, very high 24-hour urine 5-HIA. Normal is under 6. It's 470, very, very high. And so we started, and this is what their DOTA scan looked like. You see a very little tumor outside of the liver, big liver tumor, liver metastasis from small bowel carcinoid. This is just a graph of the 24-hour urine 5-HIAA. So we did 3 embolizations, and it went from 470 down to less than 100, and kind of stuck around there for a while, slowly crept up to about 300. Then we did another 2 embolizations, dropped it to below 100, then it crept up. Then we switched to chemoembolizations because the blood vessels were starting to kind of get very small, and we were concerned that particles were not penetrating deep enough. Switched to chemoembolizations, dropped it again, was back up, did another 2 embolizations, dropped it, then tried PRT. It didn't really do much to the 5-HIAA or the tumor size, went back up, and then that's where kind of we were right now, switched back to doing more chemoembolizations. As you can see, over a course of 10 years, more spots, but still predominantly in the liver. So liver dominant makes sense to treat locally. What about for hormone effect reduction? Also a very important use of these techniques. This is a person who had a lot of bowel movements per day and nearly constant flushing. We just did 1 chemoembolization with this explicit goal of killing some tumor to get the symptoms under better control. And this was very successful. These are the tumors after they got treated. They're dead. The tumors in the left side are alive and were not touched. But the number of bowel movements is down to 2 to 3 from 6 to 8. Flushing is better. And so we can use these very sort of locally applied techniques. We don't have to treat all the tumors. We can just treat a few and get to the desired effect. Another example there, this person has 3 tumors. These 2 are not growing on sandostatin, and this one is. So there's 1 tumor that's growing. So we can just treat the one. We decided to treat it with chemoembolization, treated 1 tumor, and it's already smaller. It looks dead, got a very lasting, long effect with a single chemoembolization treatment. Continuing the octreotide, the other 2 tumors are unchanged. What about as a bridge to PRT? That's another way to think of it. This person had multiple tumors and had this one bigger tumor in the left side of the liver that didn't take up nearly as much DOTA as the smaller bone spots. So we were concerned that with PRT, this tumor would continue growing because it just didn't seem to have as many somatostatin receptors and might not respond to PRT. So we did 1 chemoembolization to here and then went on to PRT. So here's the MRI before. This is the liver. This is some of the tumors. This is the one that we went after. And this is what it looks like afterwards. Just the dead area looks very different from this. Just looks like a dead tumor, responded very well, and then proceeded with treatment with PRT as it was planned. Another way where embolization is very helpful is when there's 1 or several or many very big liver tumors that could be kind of a sink of PRT material. We want PRT to distribute to the smaller tumors too, not just go to just the bigger ones. So we might use embolization or chemoembolization to just decrease the bulk of the liver tumors so that PRT has an opportunity to go to all these other areas. And so this is what we did in this location. We did 1 embolization. This is a very big tumor here. You see it's gray, so it's enhancing with contrast. And now here it's completely dead, nearly completely dead. There's maybe very little bit of residual, maybe it's just even debris, maybe completely dead or nearly completely dead, just after a single treatment to allow better distribution of the PRT material. Sometimes, well, PRT has its own kind of expected duration of action, and then it stops working. And so we can use embolizations after PRT also. And so this person had a series of planned embolizations that we did, and you can see how much smaller these tumors are. You can compare this one to this one, it's smaller. This one to this one, it's smaller. All of these ones to these little dead ones now. So it's another effective way of treating. Now you'd say, well, there's a risk of liver injury, but I would argue that the risk of liver failure after bland embolization and TACE is really quite low. What might prevent from being able to give future treatment are bad, excuse me, bad bile duct strictures, liver abscesses, infection of the bile ducts. But those are, again, are not common side effects and a very effective way of decreasing the amount of the tumor. Radioembolization of Y90 or SIRT may be different in that over the course of years that radiation deposited in the liver may have an effect and may cause a scarred down liver appearance, picture of a cirrhosis, which is what these two MRIs show. These people have came in years after having had various treatments, which included Y90. They were one of many treatments that people have gotten, and the liver is lumpy bumpy. There's fluid in the belly. There's a very big spleen. Those are all signs of liver dysfunction. This person has had a splenectomy. There is no spleen, but there's a lot of fluid in the belly, and the liver is very lumpy bumpy and very, very scarred down looking. So that can happen. And so radioembolization in general has fallen out of favor for treatment, and we don't tend to use it nearly as much. But there are some possible roles. What if these tumors are not taking up the DOTA on the scans? They're not going to be getting radiation to their liver with PRRT then. Or what if the tumors are growing so fast that you don't want to do little piecemeal treatments with TACE and chemoembolization? You want to treat with something that's much less toxic up front, like radioembolization, and then you can treat half the liver at a time and complete the treatments in the course of about a month. There is also a concern for some people who have had any kind of instrumentation of the bile ducts, whether they had a Whipple surgery, they had stents, they had tubes in the bile duct. Those people are at higher risk for infections and seem to do better with, after Y90 treatment, lower risk of infection than with chemoembolization and blend embolization. So here's an example of somebody where you could consider doing yttrium-90 because if these tumors came up very fast, they're on both sides of the liver, there's many of them, you can treat quickly half the liver at a time in a span of 1 to 2 months. There's other things that certainly we might take into account. You know, how's the health otherwise, any underlying liver problems, and how well the person feels are all very important issues. We also talk about the right timing for treatment. If there's very little tumor in the liver, then maybe doing liver-directed treatment, especially embolizations, is not the right thing because there will be a lot of deposition in healthy liver and very little will be deposited in the tumors, and that's far from ideal. And so sometimes we just continue various treatments until a certain amount of tumor develops in the liver, at least 10%. But then on the other end of the spectrum, sometimes there's just no healthy liver. This liver is enormous. This whole thing is liver. It has so much tumor in it. It has very little healthy liver. Just this little sliver is healthy, and there's already fluid in the abdomen. Treatment of the liver tumors when they're so big and so bulky will most definitely lead to complete failure of liver function, and an embolization would be very difficult to tolerate and would not be the right treatment. Where are we going from this? We are doing a pilot study. We're combining embolization and radioembolization with immunotherapy and seeing if these local techniques maybe increase the effectiveness of the immunotherapy. And so that's also ongoing with Dr. Bergson and Dr. Hope at UCSF. So wanted to leave you with some messages. So again, liver-directed therapy continues to play a number of very important roles in the area of PRRT, and interventional radiologists should be consulted before switching treatments when the liver metastases are present, because there may be an appropriate window to treat the liver. So to summarize a few things, who to treat when disease is largely limited in the liver. Okay, so it has to be largely limited to the liver, and it has to be quite stable or minimal and asymptomatic elsewhere. When to treat? When tumors are getting worse on octreotide or other systemic treatment when there's a lot of hormone side effects despite treatment, and there's high risk of carcinoid heart disease. So that 24-hour urine 5-HIA number, if that number is much above 100, we'd like to get that down to help the valves. What modality to use? We can use thermal ablation, mainly microwave, for fewer than 5 tumors, which are small, and embolization pretty much for everything else. Blend embo of TACE, we really don't know. RETNET trial is ongoing, which hopefully will help us decide whether chemoembolization or blend embolization is better. And then where does Y90 fit? Radioembolization only fits in currently in 2020 very small number of conditions when there's fast growing tumors, tumors that are not avid on DOTA scans, when we have to give a debulking treatment quickly. So that's pretty much what we've talked about. As you can see, pluses and different clinical scenarios. In vast majority of the clinical scenarios, we would prefer chemoembolization or blend embolization, unless there's rapid progression in both lobes or bile duct instrumentation, Whipple surgery, stent drains, where Y90 would be favored. Otherwise, we would really favor blend embolization and TACE, regardless of whether the tumors are avid or not avid on the DOTA scans. So that's it. I kind of went over. I hope everybody has questions. It's 12:54. Love to hear your thoughts and be happy to address questions.
So Dr. Fidelman, thank you so much for all of this. And I will say it was an incredibly thorough presentation. So much so that a lot of the questions that came in, you have already expertly answered in real time. I did have one clarifying point. When you put up the slide on RETNET, when it was originally done, it still had the title that one of the options inside of there was a drug-eluting bead. And my understanding from you, did that option get taken out, or is that still something you could be randomized to?
No, yeah, I really should have updated that slide. The protocol was updated after there were 10 patients who were treated with the drug-eluting beads. There were several significant complications, and the steering committee decided to close the drug-eluting bead arm of the RETNET trial. There are now only 2 arms: blend embolization and conventional chemoembolization with oil. No drug-eluting bead.
And I noticed that you had 13 sites, and we actually had several members participating from internationally on our Facebook channel today. And one of the questions was, are any of the RETNET sites international as well?
They were looking at opening sites in France and in Britain, I believe. I would need to check whether those sites are actually open. There were some regulatory issues that were that needed to be overcome.
And I know you did a really good, and certainly in your summary wrap up, understanding the there are a percentage of our community that aren't DOTA avid or don't have or poorly differentiated, and it seems that it looked like both the TACEs were good for, or were potentials for people who had non-DOTA avid or poorly differentiated liver disease as well. Just wanted to make sure that I caught that right as well.
You did catch that correctly. So if the tumors are growing faster and are not avid on the DOTA scans, and if they're located, well, if they're growing faster and there's a lot of them, especially in both sides of the liver, yttrium-90 would be a very attractive treatment option, because it can deliver treatment quickly, and it would not, by giving the 2 treatments in quick succession, it would not allow untreated tumors from growing out of control and causing problems. So that's probably the kind of the biggest indication for using yttrium-90. If they're slow growing tumors, that are not avid on DOTA, then we can still use chemoembolization or blend embolization. We have more time to do piecemeal treatments and potentially spare the liver the long-term side effects of the radiation. So the advantage of using chemoembolization and blend embolization is that there's zero radioactivity that's delivered. And so hopefully that means that the liver is spared the potential long-term side effects.
And I thought one of the example slides that you had was really great, showing that, going in between types of liver-directed therapy and even switching into PRRT and then going back to liver-directed therapy. How do you determine how often or how many times a patient can get a liver-directed therapy? Or obviously it's case by case, but what are the general guiding principles?
The general guiding principles for liver-directed therapy is that liver tumors have to be kind of the main source of problems. If they're the main kind of, if the tumors are predominantly or only in the liver, treating locally makes sense. Now, liver function has to be good, and the local treatments can certainly be repeated for as long as tumors are predominantly located in the liver. There is no known upper limit of the number of embolization treatments, for instance, that could be done. Is it 5? Is it 10? Is it 20? There is not really a clear number. There's of course concern that the more times you have to treat the liver, the higher the cumulative toxicity to the healthy liver tissue. And so the general paradigm is, when we are contemplating repeating additional treatment to the liver, we try to make the time intervals between the different liver treatments as long as possible. So say there is 2 or 3 treatments, it takes 3-4 treatments to do a bunch of embolizations for all the liver tumors. And then we like to wait several years before we do any more embolization. We don't want to do embolization on top of embolization. Even if there's a few tumors that have grown, it's okay. As long as they're not causing problems and they're growing very slowly, we will observe them for a long time. We might try something else. We might try everolimus in between. We might try, there's other clinical trials that could be, applied, but to prevent any long-term liver damage and liver function deterioration, we really try to space out these treatments and use them sparingly.
And I know you went over how long liver-directed therapy prevents progression, and I found it was really interesting to hear that it very much goes along the path of what your progression was beforehand as to how that timing goes. And so again, it's one of those areas where it doesn't seem to be an absolute and really is a case-by-case basis as to what the history of your disease was prior to therapy.
Right. So the main determinant of how long the treatment effects will last is how fast it's been growing. The slower it's been growing, the longer the treatment would be expected to last.
One of the questions that just came in as well over our Zoom channel was specifically, looking at, obviously, debulking surgery is another kind of liver-directed therapy. It's just a surgical taking out a bunch of liver tumors. And is there any ways to look at when you would consider debulking versus when you would consider an interventional radiology approach?
So the prevailing opinion among surgeons is that when you start doing embolizations, it can promote some scarring around the liver, and then getting to the liver in order to cut the tumors out and remove them physically, the surgery becomes more and more difficult as a result of these repeated embolizations. And so the prevailing preference among surgeons is to do the surgery first. So to, rather than start with embolizations, start with surgery, start with debulking if at all possible, and only switch to embolization when they feel like, okay, they've done all they can in terms of physically removing the tumors. But start with surgery first, and only after, only if surgery is not possible, or if repeated surgery becomes not possible, move to embolization.
And you certainly did cover this throughout the session, but um, the new paradigms with having PRT and or Lutathera and using it in combination with TACE and that you can intermix the two. It's been really interesting. Any other highlights that you want to make about the new paradigm with having a systemic therapy like PRT around with the other liver-directed therapies? And I think that's our last question for today. I'll let you get back to work.
Yeah, so one thing that I wanted to just say is, you know, I have a colleague, interventional radiologist at the University of Pennsylvania, Michael Sulin, who when he lectures, he says that local disease should get local treatment. And I think that's a very reasonable thing to say. If the tumors are only or predominantly in the liver, then doing a systemic treatment like PRT with potential bone marrow and kidney toxicities may not be the best approach. Doing a local treatment, embolization, chemoembolization, whatever, may be a better approach even before PRT. Now, I showed you various examples of where we're using just a spot local treatment to get to PRT, and that's also a very reasonable thing to try. After PRT, we have very little data on using local therapy, small retrospective studies. I would say we have to be guided by what the liver function is like. If the liver function is healthy, then it's probably okay, and we just proceed cautiously.